So now we're going to move into our clinical innovations changing the game discussion. And for this session, I'm joined by my wonderful co-moderator, good friend, Lauren Sullivan, who is the clinical education specialist with UniPoint Health. And we are so excited to guide you through this next hour of conversation about groundbreaking ideas transforming maternal health.
All right, thanks for the introduction, Megan. That was very nice. So today's speakers are leading the way in advancing clinical practice, research, and technology, each offering a unique perspective on innovation and its impact on outcomes for moms and our babies.
So we're going to start by introducing our panelists. We have Dr. Sarah Pachtman, maternal fetal medicine specialist and OB-GYN with Ouma Health, also known as Healthy Mama Doc on social media. So she brings her expertise in using digital health and education to bridge the gap between clinical care and expectant parents.
And then next, we'll hear from Dr. Donna Santillan, Director of the Division of Reproductive Science Research at the University of Iowa. Her research continues to push the boundaries of what's possible in reproductive and maternal health science.
And rounding out our session is Lauren Ronnfeldt, a medical student at Des Moines University, who will be matching for her OB-GYN residency in March. She represents the next generation of healthcare leaders and will share insights on innovation through the lens of medical education and patient-centered care.
All right, we are so thrilled to have such a dynamic group with us today. Each presenter will have about 5 minutes to share their work, and then we'll move into a short Q&A discussion. So be sure, as we're going along, that you drop your questions in the chat, and Megan and I will keep an eye on it and work to get those questions answered.
Yeah. All right, you're up,
All
Dr.
right.
Pachtman.
Hi, good morning. I just want to say thank you so much for having me. This is such an amazing conference, an amazing opportunity. And I'm really excited to share kind of some of the things that I've been doing that I think are innovations at least, to advance care and broaden our reach for advancing maternal health. And I'm so excited that this is so well attended and so many people are interested in this topic because it is so important for all the reasons we've discussed today. I'm Dr. Sarah Pachtman. Sometimes I go by Dr. Sarah Pachtman-Shetty. I haven't really figured that out yet. I practice maternal fetal medicine in New York City, but I'm also virtual, and I'll be telling you guys about that. I work in telemedicine so that I can expand my reach. This is an image of my website where I have some pregnancy coaching tools and some information for pregnant moms to be able to come, and when they feel like they're not getting the support that they need in their clinic, or if they feel that they have additional questions or just not enough time with their midwife or doctor or provider during pregnancy, they can get information in an evidence-based and real fashion. Next slide, please. I recently transitioned out of full-time in-person full scope prenatal delivery and delivery care to working in telemedicine. And this was a really tough transition for me because I had never not been in the room with a patient before. But now I live in New York City, and I work in Kansas City, Illinois, New Jersey, Texas, California, all over the place in some of these, what we call maternity care deserts. And I know that everyone is familiar with this map. This is from the March of Dimes, but it shows that there's so many places in this country where patients just don't have access to care, and they don't have, or they have to drive really far away. There's also a shortage of maternal fetal medicine physicians, and that's what I practice, high risk obstetrics, in this country right now. And I feel so privileged and so rewarded by the fact that I can be in one place, take care of my life, take care of my kid, but also be expanding my reach and expanding access to care to reach some of these maternity care deserts by technology that we are using every day in every other aspect of our lives. and it really brings maternal fetal medicine doctors we have midwives and nurses and other types of obstetrical providers directly to the patient's bedside. And then I supplement by going to these places every once in a while, performing a procedure, speaking to them in person, whatever it may be. Next slide, please. I work with a company called Ouma Health. Um, it's just been a fantastic resource, I think, for hospital systems throughout the United States. They deliver really total maternity telehealth care, and it seems like it wouldn't work. I know at first I was like, what? But I can do telehealth when I'm in my room, in my office, at my home. They wheel in a cart with my head just like this. I can see the patient, and you'd be surprised how much you can tell. And I'm working with the residents and how much information I can give to a patient just by being on telehealth and helping the teams who are there, boots on the ground, really formulate care plans and deliver the most comprehensive and delivery timing, delivery mode, and the most comprehensive care to these moms. It's absolutely fantastic. We're nationwide at this point, and I'm super excited for where this will take my career, not just literally, but figuratively. Next slide, please. I also run a social media site on Instagram. I'm a little bit on TikTok, but mostly Instagram, called Healthy Mama Doc. I do this all myself. It's very fun. It's very time consuming, but I try to myth bust. And I really think that social media, it used to be a little bit taboo, but now I can really meet patients where they are. These are moms who they're on TikTok and Instagram anyway. And there's a barrage of misinformation and myths and crazy things that people think and say that are frankly dangerous, that I can avoid them thinking that that information is true by providing evidence-based, real clinical information to these patients. There is a little bit of a line cross of what's medical advice versus not, but it's been so powerful in my ability to educate and empower these patients. Then they know what to go back and ask their doctor for. They know to say, hey, this doesn't seem right. It's more than just getting to the root cause or trusting my body. They realize that this is really something that could be done better or done in a different way. So it's been super awesome. And anybody who is a midwife or in medical pregnancy care in any way, I encourage you to jump on social media, figure it out. I can help you. I am absolutely happy to be a resource for anybody because really we need more voices like the people who are on this conference today out in the world. We need to share our knowledge and our information with patients everywhere. Next slide, please. I think we're moving on to the next presentation.
Yep, it does. Yeah, we'll go ahead, Lauren.
No, I was going to say thank you so much, Dr. Pachtman. I really love the way that you've incorporated technology and figuring out ways that we can reach people that you may not be able to see or have difficulties accessing care. I think it's amazing. So next, we are going to hear from Dr. Santillan.
Hi, everyone. It's so nice to be with you, and thank you for inviting me. And our research really does focus on helping people to understand why pregnancy matters to everyone's health, and that's what the focus of our work is. Next slide, please. So why do we do this? Oh, all the pictures didn't show up. Obviously I do this for people like my daughters, because I care about their future health. I do it for all of the women that I went to 1,200 girls that were at my all-girl high school and all the people on this call. But it's not only just for women, it's for all of the families because pregnancy health matters to everyone's health. We all, no matter what your family looks like now, we all come from a pregnancy. And so the person who gave birth to us, their health matters to our health. It affects their long-term health. Next slide. Yeah, so there's my family and my kids as they're growing up. And so even if we just think about how many people that is, if we're thinking just about women, well, in my home state of Iowa, that's over 500,000 women that are of reproductive age, but it's so many more people than that that are affected by health during pregnancy. Next slide. And so if we think about who has been affected, I've already kind of given away the answer that everybody's health has been affected. And so, oftentimes when I'm giving a presentation, I ask people to raise their hand if their health has been affected by pregnancy, and you get some women and sometimes one guy, and people laugh at the guy, but no, because he came from a pregnancy, everybody's health is affected by pregnancy. Next slide. And so it really does matter. And our research is even showing that it's not even just the health of the mom that matters to the health of the children during pregnancy. It's the health of the male partner as well, because they have a contribution. And so that we're talking very much about intergenerational health and all of society. And so this topic really should be more at the forefront of research, because it is I would argue, one of the few topics that actually applies to everybody on the planet, without exception. Next slide. And that is 7.7 billion people. So I just think that it is shameful that women's health research and pregnancy research gets so little dedicated to it. Next slide. And there's so many things that you think we would know. There's a lot of things that we have pieces of, but we don't fully understand genetics and environmental exposures, and even how activity or inactivity and social and structural determinants of health overall impact short and long-term health of the birth parent and the offspring, and how that works for multiple generations. And so there is so much work to still be done, and that's part of the work that we do in my lab and that we help facilitate. Next slide. And if you think about how understudied pregnancy is, I looked in PubMed the other day, and there's 1.2 million papers about pregnancy. And I'm not saying we shouldn't study cancer. It affects a lot of people. It affects people in my family. But there's 5.4 million papers about pregnancy about cancer in PubMed. So quite the disparity between something that affects literally everybody and something that affects a lot of people, but not everybody. So where has our focus been over the years, and how do we help shift that focus to really gain more understanding about pregnancy? Next slide. But why has it been understudied? People have been worried about, if you do research, then you might harm the fetus. And so pregnant people have been nearly excluded from clinical trials for so long. People fear the liability. Pregnant patients themselves were designated as a vulnerable population until 2018, so they had the same rights as a child or a prisoner for deciding if they were going to participate in research. Pregnancy is complex. There's physiologic changes through pregnancy, so you have to also study over time, which makes studies more expensive. And so for a long time, the male body has been the default for biomedical research, making pregnancy a low funding priority. And there just hasn't been a lot of data about it in a very granular and distinct way that we can use. So all of these things have contributed to making it where pregnancy has been undervalued and understudied and underappreciated for too long. Next slide. And it's not just pregnancy, it's all of women's health. And so it wasn't until 1993, and I'll give this away, I was still in high school at this time, when the NIH began to require that you include women in studies. 2014, I was long out of high school by then, but that the NIH began requiring you address the sex of cells in animals. Not that you had to include them, you just had to say why you were excluding women if you did, or cells that were derived from females. And it wasn't until 2018, as I mentioned, that this research rule was changed to remove the vulnerable designation for pregnant populations and let them decide on their own if they want to participate in research. Next slide. And I think part of the challenge is that pregnant people have been missing from the conversation. They're historically an underrepresented population in research. And so it's really important that we give a voice to the people who have lived experience to tell us what they care about for research topics. What are the outcomes that they want to know about? What are the approaches that they think would be valuable for the studies? And use these questions to help fuel future research. The people who are affected by the research should be involved in the research, and that's been part of my passion. Next slide. And how we've done this, we've worked with groups like Healthy Birthday and other organizations to have listening sessions prior to designing and implementing projects. We include people with lived experience in advisory committees or on community advisory boards for research proposals. And we don't do this in a way that's superficial, where it's just we're checking a box because it's required. We honestly listen and value the opinion. And then even in the way we do research, where we're looking at what other questions that people are asking. So if they're going and they're using apps like Count the Kicks that has Ask Anna in it, or if they're going to social media support groups, what are the questions they're asking there? Because it's what they're not getting from their providers. And so we use that to help fuel our research. Next slide. And so this is my last slide, I believe. And so it's talking about multiple generations when we're caring about pregnant people. We're not just talking about women, and we're not just talking about pregnancy-related health. We're really talking about lifelong health for everybody on the planet. And so it's a really important topic that deserves more attention. Thank you.
Thank you, Dr. Santillan. And now we're going to turn it over to Lauren to kind of wrap up our just introduction slides here, and then we're going to open it up to questions. So Lauren Ronnfeldt, we have two Laurens on this panel, but go ahead, Lauren.
Hi, everyone. Thank you for having me. My name is Lauren Ronnfeldt. I'm a student at Des Moines University, and I'm planning to go to OB-GYN residency next year. I have been involved with research with the University of Iowa for the past couple of years, and over the past year or so, I've been able to work with Count the Kicks on some of their survey data for their app. And what I'm going to do over the next few minutes is kind of go over kick counting and um, also go over some of our findings from analyzing the survey data and from mothers who've used the app. So for kick counting, ACOG recommends beginning around 28 weeks of gestation, or 26 weeks when you're considered high risk. And what counts as a movement is really anything. So it's not just kicks, but it can be rolls, kicks, swishes, pushes, anything except for hiccups, because those are involuntary movements. And so when you start kick counting, what you're going to do is sit or lay on your side in a comfortable position. And then you're going to track your movements at the same time each day. A lot of times you want to do this when baby is more active. So that can be more so, after a meal is going to be a time that baby's more active. So that can be a great time. Next slide, please. So the Count the Kicks app kind of aligns with this. So when you sit down and start counting, you'll press this button, and then as you go, you'll just keep pressing the button until you reach 10 kicks. And you can kind of track and record your movement patterns over time. So in the graph on the right, you see the amount of time it takes to reach 10 movements over time. And then this app has a lot of other great features like a contraction timer and reminders to be counting your kicks each day. And then this is all of the data that we collected, but it's kind of overwhelming. I just kept this in the slides for people to be able to go back and look at. But I'm kind of just go over the findings that we found. So for kick counting, we found that 65.5% of users reported reduced anxiety, 58.8% reported increased bonding, and 80.4% of users felt that kick counting was useful. And then another thing that we found with this was only 5% of users found that using this app and kick counting actually increased their anxiety, which was really cool to see. So really most people felt like the app was useful or it reduced anxiety, which was really reassuring to see. And then when we compared rural and urban populations, we saw increased benefit for mothers in urban areas, which is something that we kind of want to focus on in the future is how can we make this app more accessible and usable for mothers in those rural areas, because this is really something that can be really great for mothers in rural areas because it's just harder for them to get into their doctor's office and to get care. And then when we compared high and low risk pregnancies, we actually saw increased benefit for mothers with high risk pregnancies, which was also really interesting to see because kind of the concern is, with these already high risk pregnancies, are you going to make those mothers more anxious with adding kick counting into the mix? But it actually helped them feel more reassured when they used kick counting.
Awesome. Thank you so much, everybody, for that intro. And obviously, I could talk lots about Count the Kicks. So I'll just add part of the work that we're doing too is around the collaboration. And that's really the common theme of the last 2 days is connecting with community partners and doulas to make sure that everybody is aware of the importance of tracking fetal movement. And that while we do have a free app, we also have paper kick counting charts and things like that, and following those evidence-based practices. And then partnering with people like Dr. Pachtman, who can help share our work on social media with a generation that is highly, highly involved and growing up in this world with social media. And we're just really thankful for Lauren and her work and Donna's work to really continue to add to the data and the evidence behind the importance of tracking fetal movement, how it helps to decrease anxiety, increase bonding. So we're excited to continue this conversation with them. So this session's really about action and looking at the data that we have in the research and turning that into action and inspiration. So, and really learning how innovation can translate from research and clinical settings like we just heard about to real world impact for families. So we're going to dive into some of the questions. I'm going to stop sharing so we can see everybody. And so I'll start with Dr. Pachtman. Dr. Pachtman, you've built a huge following as at Healthy Mama Doc. How has a digital connection changed the ways you care for patients in real life? Oh, where'd she go? Okay, we might come back to her. I thought she was on. We'll come back to Dr. Pachtman. Go ahead.
All right. Yeah, so Dr. Santillan, your work bridges science and clinical care so beautifully. And as someone who's benefited from both as a patient and a healthcare professional from the research that you've continued to do, how do you, I mean, you kind of talked about how the research has changed, but how do you see that continuing to change? And how do we work to get the people that need to be at the root of the research involved in that?
Yeah, so like I mentioned, it is great to see families more involved, and it is not just the females. We do have the male partners involved as well. And so I think that's really important to the research, and I think that collecting more data is really important. And so we're trying to do that and to really think about all aspects of a person's life. And so, yeah, the male and the female partners, yes, we collect all of it, honestly, but we collect the biological samples from the male partners too. So everybody is at the table, and I think that that's really important. But we're also thinking about not just biological samples, we're thinking about environmental samples and just so many things that people are exposed to try and improve the research. And I think that we keep having things like this and keep letting people know that they should be voicing their opinion and that we do care about the community's opinion and that their voice matters, because so many people just think science is kind of something out of touch. And I think that's something we need to communicate with the scientists is they have to do a better job of engaging people and explaining things. And just to keep reiterating the importance of having everybody involved.
Right. There's Dr. Pachtman. Dr. Pachtman, again, you built that following at Healthy Mama Doc, and I'm just wondering how the digital connection and how you've done that has changed, and if it's changed any way you care for patients in real life. And I love that you said they bring you in with a video on your head on a video. Like, that's just so funny.
No, that's a great question because I was really it made me anxious at first. I really was like, am I going to be able to do this? Because I think a strength of a good maternity care provider is connection with patients. You really have to meet people where they are, and it's really hard to connect over a screen. But more and more, as we especially got through COVID and we got used to it, and FaceTime is a thing, and Zoom, and we're meeting digitally more and more. It actually kind of seamlessly integrates into my care for patients in person. Like I will have multiple consults on the video screen, and then see the patient in real life, and it's like, oh my gosh, we're here together. I can see you in person, and it's actually so nice. I can arrange to be in town, hopefully for their deliveries. I can speak to them more frequently. And actually, it gives me more time to connect with patients versus having them come in person all the time. Oftentimes in their homes, so they feel more comfortable, more secure, more safe, and they're sharing information with me that really helps me guide their care in a great way.
Perfect. Thank you.
All right, Lauren, wondering if you would tell us what you want people to know about your experiences with rural maternal care and how you think that we can improve care for families in these areas.
So I've had 4 rotations in rural areas during medical school, and each of the hospitals that I did those rotations at, they didn't have labor and delivery units, which means they didn't do any deliveries. They also didn't have any OB-GYNs on staff. And so I was known for having a lot of maternity care deserts, and it's hard for hospitals to keep L&D units open if they don't have high enough volume. So with that, if they don't have an L&D unit, they may not have OB-GYNs on staff. Ways that we can improve care for families in those areas would be having prenatal care appointments, like outreach for specialists. The OB-GYNs would come like once a week, and patients could go to those appointments, or having virtual care options, kind of like what Dr. Pachtman talked about. And then also, if family medicine providers in those areas are comfortable with providing that care, if they're able to do that too, that's also a great option. I think also finding ways to just integrate more virtual methods, the telehealth and applications, kind of shifting the education you're giving patients and making sure that you're still finding ways to connect with your patients. If they're choosing to use an application, making sure you're helping them understand what is an emergency situation that they need to, directly call their provider or go to the ER versus what is something that they can use an application for or a more virtual approach.
Lauren, is your goal to end up in rural areas then?
Yeah, I think it would be cool to kind of do more so the outreach. So like maybe you know, for example, like if I practiced in Iowa City or Des Moines, like either of those areas and, deliver at a hospital in the city, but then being able to like maybe one day a week or 2 days a week go out to some rural area and provide care there and do those prenatal appointments.
And then you're going to take Count the Kicks information out in those rural areas
Mhm.
and talk about it. So we're all connecting the dots, right? We're all connecting the
Yeah.
dots. Dr. Santillan, uh, translating research into practice isn't easy. And I know we talk about this a lot because I'm not a researcher and I like to surround myself by all the experts in this field and you help me understand things and it's amazing. But what do you think is the biggest barrier and kind of you talked about a little bit earlier about what keeps pushing you through, but would you like to elaborate on that a little bit more?
The biggest barrier for research is funding.
Mhm.
I mean, if you think about the biggest research dollars usually come from the government, which is not on at the moment. And then the priorities at the NIH just typically have not been high towards pregnancy in specific. So right now, for example, not many of the institutes publish their pay lines for how much they pay within the NIH, but the Cancer Institute published their pay line. And so they were currently paying 4%. So that means 96 out of 100 cancer grants aren't getting funded. And that's a lot considering the Cancer Institute has more funding than some of the other institutes, including the one that funds pregnancy and child health. So if they're only paying 4 out of 100 grants, you can imagine how many related to pregnancy are actually getting paid. And so then everybody is looking to foundations and other ways to get funding, and that gets more competitive. And it's really hard. And unfortunately, you need the money to drive the research, which is just kind of as much as we want to do. We have to pay people, we have to pay participants, we have to pay our staff. And so it becomes a challenge. That is unfortunately the main reality is that's what holding back research a lot. And then you just have to make people aware of that this does impact every single person and this should be a higher priority. And so when you make more people aware of it, it does become a higher priority for participation. And and for having announcements and having people behind keeping those opportunities open for research.
Absolutely.
Dr. Pachtman, you've seen lots of digital innovations, but what's one thing that you think is really impacting our maternal outcomes and something that you really wish every hospital was using or utilizing?
Ooh, that's a good question. So I think that our maternal outcomes are getting, for lack of a better word, worse because it's multifactorial, really. There's systemic racism. We're older, we're more obese, we're more diabetic. Our food systems are a disaster. Our healthcare system is broken. I mean, these are just the truths, and it's really tough because you're a patient trying to navigate a broken healthcare system. You're a doctor trying to work in a broken healthcare system. Like we're all kind of losing here, and it makes it the experience of seeking healthcare in the United States right now is miserable. It's really tough. It kind of sucks. So, those things kind of play into this, I don't like perfect storm of poor maternal outcomes. I think that one of the things that we could do is make the interface between patient and provider easier. When you have 3 kids at home, your SNAP benefits aren't being renewed. You have to take a bus to a plane, to a train, to a car to get to the closest clinic. Make it better. Make it so that patients don't have to do that. Home visits, remote visits, whatever we can do, and get phone systems that work. Apps, reaching people and making the interface more seamless, I think will be one way that hospitals and hospital systems especially can improve our outcomes.
Thank you. I have to go off script a little bit because there is a question or a statement in the chat about AI and using AI, or how do we think AI could help improve maternal health outcomes. And AI, machine learning, is such a buzzword, and it's not going away. Like it's not. And we're at Healthy Birthday, we are really incorporating AI, machine learning into our work already with our Ask Anna feature, which is a free way people can ask fetal movement monitoring questions and get evidence-based answers from research. But I would love to lean on your expertise. All 3 of you, feel free to chime in about what you're seeing in this space or what you're doing in this AI space, and how you think it could improve. Do you think it could help improve maternal health outcomes?
I have a lot of thoughts on this, so I will chime in first, and please, if anyone else has anything too. Okay, AI is here to stay, and it's great when used correctly. And I think from a provider perspective, it's making our administrative burden much less already, which frees us up to do what we're supposed to do. Like I tell people all the time, I'm like, listen, I'm a doctor. I am not a note filler outer, EMR learner, computer interfacer. Sometimes I can't even figure out how to work Zoom. And I have figured out these platforms just enough to be able to do what I'm supposed to do and what I know how to do. And AI is augmenting that in a way that it allows me to see more patients and give my care in a more extensive and real kind of way. Then the administrative stuff on the side is kind of being helped by AI. So that's one way. The other thing too is, like Megan said, bringing evidence-based answers to people without them going on TikTok and reading about who knows what. They can get information as long as it's vetted and really double, triple checked that is sound and tells them what to do and really tells them when to sound the alarm. For things like preeclampsia, I have patients that don't know what a blood pressure goal is, and they can ask an AI app. And I think that that's such a great idea for hospital systems to have and employ, to be able to ask someone, get information quickly, and then know what to do with that information. And that somehow in a human interface is so many steps and so many phone calls and so many barriers. And AI can really release some of those barriers for us.
Yeah.
And I think in research for machine learning, it allows us to just take hundreds of thousands of lines of clinical data and so many pieces because so much goes into health. And a lot of times researchers will look at it from their particular lens. So if I'm interested in genetics, I will be looking at, polymorphisms and changes in the genes or differences. But if I'm interested in environment, I might be looking at chemical exposures and outcomes. Or I might be interested in, if I'm a people who are interested in clinical data. Well, maybe I'm interested in blood pressures and then what the clinical outcomes were. But we can use machine learning and we can put all of this data together for hundreds of thousands of people and really churn through it and really help us understand what variables are the most important. And then that can lead to more precise research questions. So I think that it's useful in that way to really better interpret the data and to put more pieces of different data together.
Yeah, thank you. And Lauren, I don't know if you have any other thoughts. We have another question for you too, but I will just add, like, I agree with Dr. Pachtman, like it's here to stay. Like, let's figure out how we can use it for good. And I think that's key.
Yeah, and I like the idea of using it to help kind of sift through some of that information. I hadn't really thought of it that way. So some ways that maybe I can look at incorporating AI.
Or like from a research perspective too, like Donna said, it's so great to, sorry, Dr. Santillan said, it is so great to be able to apply it to statistical analysis to get real. You can, as we've seen on the news lately, interpret data however you really want. AI can help us with that, with the actual correct statistical method to review hundreds and thousands and billions of data points and get us true answers to questions that aren't open to interpretation.
Yeah.
All right. So Lauren, as a student, you're getting ready to enter the medical field as a doctor. What excites you the most about how innovation is continuing to shape maternal care?
I think kind of related to what we've been talking about, just all of the tools and technology and applications that are being developed and that patients have access to. I think all of these options can really empower patients to be more proactive and more involved in their care. I think as providers, just working to find ways to integrate that into patient care, to provide more personalized care, but also, provide more options for people who may have a more difficult time physically getting to appointments, like people who live in rural areas, providing those options, when it takes them a lot longer to get into the office, and just finding ways to kind of decrease those barriers for them.
Yeah. Thank you. Dr. Pachtman, sometimes there's maybe skepticism about using social media or apps in clinical care. What would you say to those who still see digital tools as maybe a nice to have, but instead of essential? I said, depending on who you're talking
I
to.
would, I am asked this question frequently, and this is what I do say. I say that digital tools are here. Everyone has an iPhone or some sort of smartphone, and people are going to use digital tools, whether we like it or not. So we can even either give them the right digital tools or leave them to their own devices to find the wrong ones. So tools are here. Let's use that reality to our advantage and help us reach more people with the best information that we can and the improving access. And let's make the tools work for us. We have a huge, tough job at Baseline. Using these tools that are here anyway to help us is only a positive thing.
Yeah, I would agree. Dr. Santillan, you've been at the forefront of innovation in reproductive science. So what's a breakthrough or technology change that you've seen that you think is really going to change the game in the next 5 years?
I really think that we're going to keep leaning on biomarkers. and as a way to help us identify who's at higher risk and to stratify the care that they get and that they are at the appropriate location. As Lauren mentioned, there are a lot of places in our state and in other states that don't have labor and deliveries. And there are places that do, but they have like 2 units of blood. And maybe that's not where you should be if you are the most high risk. But, sometimes pregnancies are totally fine until they aren't. And so if we have ways to help us identify who's at a little bit higher risk and really needs to be at a different location so that they're there when it is the emergency or instead of being flown across the state, that will really help improve outcomes for the parent and the child. And so I'm excited about the expanded use of biomarkers. And then just as I mentioned before, the idea of incorporating so many more data points with the use of machine learning and the way that we are incorporating environmental exposures and genetics and clinical history and social and structural determinants of health, really to give more granular and personalized medicine to patients, I think is very important.
Perfect. I have one more question for Lauren, and then I'll open it up to audience questions. And my colleague Kimberly is sending me some in the chat from audience. So we have several to get to, and so we have perfect time for this. So Lauren, what have you learned about the importance of patient education and engagement, particularly like tools like Count the Kicks and improving outcomes? Like what have you seen in the...
I think with looking at all the data from the Count the Kicks app, something that we really saw was the importance of tailoring patient engagement. Some groups really connected more with the app, and when we looked at it, it was more so the urban populations. And so, taking the time to see why did those people in the rural populations not respond as well to the app? Part of research is understanding why some people don't respond the same to some tools. So, in the future, if we're able to find ways to figure out why that is, I think that that could be really powerful to be able to make, the Count the Kicks app or really any sort of application like that more accessible for people. And then I also just feel like patient education and empowerment is one of the most powerful tools we have to really help improve outcomes. And so I know you talked about the Ask Anna tool in the Count the Kicks app and all of the options in the app that you have to access free resources. I think that that is really awesome to be able to provide patients with more resources and let them have more benefits from the app and hopefully improve outcomes as well.
Yeah, and I think one of the things when we look at urban and rural is just, where we started in Iowa, and we've had such a saturation here. And as we branch out and those connections and collaboration, it'll be interesting to see that rollout in the next 2 to 3, 5 years and really see that grow as more broadband Wi-Fi, things are created too. I think that will be interesting to see the data again in another 6 to 9 months, probably, honestly. But so I'm going to open it up to some audience questions, and Kimberly has sent me some. This is for Dr. Santillan. With the delayed focus on research that includes women, what do you think are the most important areas or topics to prioritize when it comes to research?
Oh, that's a tough one.
I started with a heavy one.
You did start with a very heavy one. So I think that I think we should start with what we have, right? So we have a lot of clinical data that really can be used to make better data-driven decisions. And so I think that using bioinformatics, I think, should be a major area of focus because we have the data. We have the data from a lot of different hospitals, and we can incorporate it together. And so we're collaborating with other hospitals that are similar to us and that are more different from us because we, thankfully, when everybody is using one of a few major medical record systems, we collect the data in very similar ways. And so it's not hard for us to tally up our data at each site and put it together and look at outcomes. And I think that is going to become more important. And I think that's a low-hanging fruit, but very important place to start. And so I think we should be using that very granular clinical data that we have.
Lauren, what inspired you to pursue maternal health?
Prior to medical school, I worked as a medical assistant at an OB clinic. And while I was there, I just really fell in love with kind of the clinical side of patient care. And I loved being able to work with women and, you know, um, just advocate for their health care and, find ways that I could be more involved in my community and be more involved in women's health research as well. Um, I think overall, I'm just really passionate about women's health and learning about it. I love learning about it every day. And then all of the options that I have to really be involved in it and um, just get involved in my community and advocate for women.
Dr. Pachtman, there's a couple questions about Ouma. I'm saying that right? Ouma?
Yes. Yes, Uma.
Ouma. How does Ouma handle the most physical aspects of prenatal care, like measuring fundal height or cervical checks or labs for someone who is accessing it from their home rather than in another provider's office?
So we really work hand in hand with nurse practitioners and midwives who are on the ground. So there are times where we'll see a patient who is houseless or has not had any prenatal care, and I can order labs from my computer and direct them to a nearby lab, and we have resources to get them into Medicaid programs and into substance abuse programs all over the country. Like the network is incredible. So, we have a maternal fetal medicine team, a midwifery team, a nursing team, and we collaborate amongst our teams to get the patients what they need. And sometimes it's just helping them find a clinic who can handle their pregnancy, and then they can go in person for prenatal care, and we can help coordinate the care at the labor and delivery that's best for them, be it a little bit farther than we would like because so many labor and deliveries are closing, but we can see them virtually and then have them have their fundal height checked by a midwife in a clinic in South Detroit, wherever they might be. So that's a great question. I can't touch a patient from my computer screen, as cool as it is, but I can do so much as far as prescribing medications, understanding risk factors, risk management and stratification, and getting people to the resources that they need.
Does Ouma contract with doulas?
Absolutely, yes. And it's one of our best resources. I mean, every patient needs a doula, I think, but having a doula and having a network of doulas within our system that we know and work with really helps us facilitate care and bring care into the patient's home and work with patients, and just the education and empowerment and feeling support of having a doula makes all the difference in the world for these patients.
So how would they get involved, or how would they just, if they're doulas? Because we have a doula panel later, y'all. Like, stay tuned. But how would they get involved with Ouma?
Send me an email to Sarah, SARAH, at oumahealth.com, and I will
We'll put that in
facilitate.
the
I'll
chat.
put it in the
We'll
chat.
put it in the chat, and we have that web page. But I'll throw it back over to Laura now to ask a couple other questions. Oh, Kimberly's so fast.
She is. All right. So this is kind of a question for all of you. What kind of trends are you seeing surrounding fertility issues, if any?
I can answer. Fertility is becoming, um, uh, okay, it's hard to say because infertility is becoming more common, but is it because people are able to interface and have workups more? Is it because they have more comorbidities, or is it something else in our ecosystem that's driving this? It's probably just like most things, multifactorial, and it's patient dependent. I am seeing increased access to infertility services, which is so great. And my baby's an IVF baby, and for no other reason that I waited, I don't want to say too long, but I was doing other things before I was ready to have my little man. So I had to interface with the system also, and it's so hard. It's just like another freaking step to get to where you need to be. And I think those clinics are expanding, and there are more services for really high risk patients to access things like surrogacy options or IVF clinics where they can have IVF because of a genetic reason or a reason that they really like can't get pregnant on their own. So I think yes, infertility is more common. Why? Many reasons. And what are we doing about it? Improving access.
Dr. Santillan, do you have anything to share?
I think there are a lot of different trends in fertility research. One of the things that the University of Iowa has particularly been involved in, and it's not my work, but it was led by Dr. Brad Van Voorhis, who was the division director of REI for a long time and our chair. He really led the single embryo transfer program and looking at outcomes because for a long time it wasn't uncommon to put like 2 embryos in, hope that one would take, but it would lead to more multiple pregnancies, which have oftentimes more adverse outcomes. And so identifying which patients are really optimal for just putting in 1 embryo and reducing the number of multiple births, which helps improve health outcomes for the mom and the baby. And so I think that's a great trend and something very practical that has come out of Iowa recently.
While you're talking, there's another question for you, and then I'm going to call on Kimberly to come on and ask a couple more. So this question, Dr. Santillan, is, can you explain what it means for pregnant women to be removed from the vulnerable population as it relates to research?
It means that they get treated like an adult that they are and make the decision themselves with their own brains if they want to be able to participate in that project. And so if someone comes to you and says, do you want to participate in the study? You can weigh the risks and the benefits, which have to be explained to you as part of research, and make the decision. It is not somebody else saying, no, there's too many risks and they can't be involved in it, and you can't even present the option to them. And that has been the problem with research. Pregnant people weren't treated like grown-ups and they weren't allowed to make their own decisions. And when you don't have people involved in research, we don't have the data to say if something is safe or not. And so if you go back a long time ago, that was the problem with thalidomide, which didn't happen in the US, thankfully, but it happened in other countries because there weren't pregnant people in the original research, and they took data from old white men and tried to apply it to a pregnant population. And it had tragic outcomes for pregnancies and for the outcomes of the children because pregnant women weren't in the research. And in that case, that's a good thing, but it also, because you didn't have it on a small group of people, a whole lot of pregnancies, millions of pregnancies suffered because of it. And so that is the difference. It treats pregnant people like grown-ups and allows them to make their own decisions and weigh whether they want to be involved or not.
I feel like there's so many hashtags out of this so far, like treat pregnant women as adults and grown-ups, and what Gabby was saying earlier. So thank you for that. You saw the emojis in the chat, but that was a great answer. Kimberly, what are you seeing in the chat? We have about 5-6 minutes of more audience questions, and then we'll end on one question for all the speakers.
Okay. Dr. Pachtman, you talked about using your social media channels to help bust myths related to maternal health and to pregnancy care at Healthy Birthday and Count the Cakes. That's one of the main things that we try to do, as well as kind of busting some of those common myths related to a baby's movement in pregnancy. So for you or any of you, what is some of the biggest myths that you're seeing that you are trying personally to bust and to overcome and make sure that there's good evidence-based information out there available for pregnant women?
Well, currently I'm working on Tylenol and autism. So that's been a campaign for my last, I can pull up my Instagram and look, but I've done several posts, more than I would like to have to admit about that. I had oh gosh, it's lots of Tylenol going on here. I'm doing a lot about vaccines. I always have done a lot about vaccines. The way Healthy Mama Doc became a thing was because I got my COVID vaccine at 16 weeks with my IVF fetus online. Like I posted myself, and it was real controversial at the time, but here we are. I do a lot of uh, um, there's a lot of silly stuff. Like I'll see a weird TikTok about somebody who I, I would have to like get back to you with like specific ones, like silly things about um, things like eating dates. Yes, sure, it's not going to hurt you and it can help you, but don't feel bad about yourself if you had a C-section and failed your induction, even though you ate dates every single day. Stuff like that.
Yeah. And when
But
I met Dr. Pachtman in person a couple weeks ago, and we did do a social media message together. So she's a pro. I am not.
I felt like you were very well versed in pro, a little distracted by my bubs, but
He did fall
awesome.
down. Yes, her son was in the background. It was cute.
Was
Kimberly.
it?
It was. One more, Kimberly.
Sure. With the current political climate and staff shortages in hospitals and public health, what do you all recommend to keep us moving, to keep us making progress and momentum in the maternal health area?
Who wants to start that one?
I mean, I can chime in a little bit. I think that corporatization of medicine is challenging for physicians and maternity care providers to work in those systems because there can be lots of limitations that make it not a preferred place and to practice. And those are the systems that are giving care to a lot of these patients. So making it, it's like kind of a two-way street, making it better for the providers so they can give the care that they want to give without sacrificing their own values, would be helpful. And just expanding reach. I mean, we need more Ouma.
Donna?
I would say that it's important to keep lots of different populations involved in research and lots of different healthcare settings. And so, we try and take research out of just an academic medical center here where we get a lot of overly highly educated people participating in our research. And research needs to look like the map and it needs to include everybody in it. And so if you are asked about participating in research, I would just ask that people really do consider participating in it because everybody contributes and will help improve the health of the next generations, even if you don't directly benefit from it. And so it really is important to get as many people from as many different locations and backgrounds and different jobs and different environmental exposures and everything to really be participating because that's the only way we're really going to help make everybody healthier is to have better representation in our research.
I think also finding ways to be involved in community organizations that really resonate with you, um, whether that's through your time or money. I think a lot of nonprofit community organizations and research, um, a lot of them are struggling right now just with all of these restrictions and with having less funding. So, um, I think we've heard a lot throughout the day and throughout yesterday too about a lot of really great organizations. So, like, if any of those organizations resonate with you, finding ways to be more involved with those and help those organizations out.
I know we benefit from it and we're grateful and thankful.
And Lauren, whenever you're ready for your maternal fetal medicine fellowship, will you please give me a call so I can get you into a fellowship and write you a recommendation letter?
For sure.
Love the connections that virtual has allowed us to have that we couldn't have before, right? So there's so many pros and cons, but I think we're finding today definitely more pros than than maybe we realized. So before we close, I'd like to ask one final question to each of you. What is the one key takeaway that you really want our audience to bring back to their work? So Dr. Pachtman, we'll start with you.
Virtual care is important. It's the future. It's changing the game. And AI and apps and reaching people, meeting them where they are is happening. So make it work for you.
I love that. Dr. Santillan?
I think that research is easy to participate in, and it really is beneficial not only to every person, but to the future generations. And I think that it makes a great contribution. And I hope that everybody who has participated in research knows how appreciated their contributions have been. And for those that want to, please find a way and to just advocate for research. It really is truly important.
Great.
And
Go
I
ahead.
think that one takeaway from this is just being open to new ideas and innovations and resources and the benefits that they can offer you or your patients.
Wonderful. Thank you all so much for your valuable insights. I see some more questions coming in the Q&A. There's a couple for you, Dr. Pachtman. Feel free to answer those. I think you can as a panelist, you just can type your answer and I think everyone can see them. And then, yeah, we'll make sure we get to all of those and send those out as well. I hope that everybody kind of hears this and knows there's practical ways to get involved, to bring to your work, whether it's innovation and starting to do more and digital side and social media and using your voice as a professional and evidence-based that way, using your research, engaging families in new ways, going out into those rural areas, any ways that you can engage, I think are really, really key and important. So thank you so much.
Yeah, and thank you to the audience. Your questions and the work that you're continuing to do in your community, the fact that you're sitting here today wanting to hear about ways we can improve care for our families, our patients, is so incredibly valuable. And it says a lot about the work that we as a whole are trying to accomplish. So we really hope that this brought you inspiration, maybe some key takeaways to look into your own practice or to figure out how to implement within your systems, and actionable ways to improve maternal and infant health. So now I'm going to turn it back over to Megan and I'll let her introduce what's up next.